talk about Scissoring section. So first let us see what are the different types of Scissoring section. So Scissoring section is divided into two types. One is the classical Scissoring section and the other one is the lower segmental Scissoring section. So in short form it is called as LSCS and this is called as CCS. So classical Scissoring section is an incision which is given on upper uterine segment. For example, at mid-uterus, if you give incision like this in the upper uterine segment in the midline, this is called as classical Scissoring section, and this is also called as Sanger's incision. Okay, and the upper segment, if you give the section here, actually the upper segment will be very thick and it is a contractile part of the uterus. So disadvantages are there is more bleeding. The repair is also different because it is very thick and healing is not good, and the risk of rupture in subsequent pregnancy will be high. So in the case of a female who is having previous history of classical cesarean section, following deliveries also she'll have cesarean section because it is very hard to bear a normal delivery in the case of this upper segment uterine cesarean section. So especially the risk of rupture in following pregnancies is 4 to 9% in following pregnancies you will have risk of rupture. Now coming to lower segment uterine section, this is the most common cesarean section. Okay, and it is divided into two types. The first one is care. As I said, the most common cesarean section is lower segment. In that also the most common is care incision. So what is this care incision? For example, this is uterus. Here like this you will give an incision, lower segment like this. Okay, and the second one is chronic or also called daily incision. So chronic or daily incision is what? For example, this is uterus. You'll give in the lower segment like this. Okay, so most common is care incision. This is where it is. Chronic dealing is very rare. Thus, if you see the shape, it is like a curvy linear shape which stretches during labor. So actually, lower uterine segment is non-contractile relatively, so we can do here. Advantages is here it is very thin, so bleeding will be less, and repair is very easy, and healing also will be very better, and there are fewer chances of rupture in next pregnancy. So in a female who is having previous history of lower segment cesarean section, then for her the normal delivery chances are more in the case of next pregnancy. So that's why here the rupture in next pregnancy chance is just 0.2 to 0.9. You can neglect it, but in the case of classical cesarean section in the midline incision, this is leading to 4 to 9% chances in the next pregnancy. Now coming to in almost all cases of lower cesarean section, vaginal delivery after cesarean, you can do a trial of scar. So any vaginal delivery after the lower segment cesarean section is called as VBAC. That is vaginal delivery after cesarean section, or it is also called as trial of scar. Okay, so after lower segment uterine cesarean section, due to an indication other than contracted pelvis, there is previous history of at least one lower cesarean section or previous history of two lower cesarean sections, two lower segments cesarean section. But whenever female have a previous history of three lower segment cesarean section, then again you need to do the cesarean section itself. But in the case of one or two previous histories, no need to do. You can go to this VBAC or trial of scar. Now coming to in case of classical cesarean section, even if one previous history, then you need to go for cesarean section itself. You can't do trial of scar or VBAC. Now coming to indications of classical cesarean section. So in what conditions you need to do, even if when access to lower segment is difficult, in cases like lower uterine segment is adherent to bladder. If lower uterine segment is adherent to bladder, and if you want to do lower segment cesarean section, even bladder may cut, right? So indication is, so here the indication is classical cesarean section. And the next one is severely contracted pelvis. If pelvis is severely contracted, you can't do normal vaginal delivery here, so you need to do classical cesarean section. And in the case of cancer pelvis, cancer cervix, in the cervix there is cancer, so you need to do cesarean section in upper segment itself. Now coming to when there is morbidity, adherent placenta attached to lower segment, in the cases of placenta previa, excreta, in all these conditions also you need to do classical cesarean section. Lower segment does not form in the case of early preterm cesarean. To deliver in the case of transverse line, midline incision is better. So in all these conditions. Now coming to chronic incision. Chronic means here the indication is constriction ring. Whenever there is constriction ring, then you can do chronic incision. Here the chances of uterine rupture are 1 to 7%. Chronic means, I said, in the lower uterine segment you will give like this vertical incision, right? So it can cause bladder injury. Only if extended. Okay, now coming to anesthesia and Robson's classification. So let us start with anesthesia and Robson classification. So the preferred anesthesia is spinal anesthesia. Okay, that is at the level of T4 vertebra, you'll give the spinal anesthesia. And let us see now what are the indications for general anesthesia. If there is severe fetal distress, then you will give general anesthesia. And in certain heart conditions, like you can remember with the mnemonic SHEP, that is intracardiac shunt, HOCM, decreased ejection fraction in the case of severe atrial stenosis or atrial aortic regurgitation, and P is pulmonary hypertension. So in these cases, in certain heart conditions, we give severe in the case of severe fetal distress, in this case we will give general anesthesia. And in the cases of severe preeclampsia, that is if umbilical Doppler shows AEDF or REDF. What is AEDF? Absent end diastolic flow. For this we need to do cesarean section at the rate 34 weeks. And for reversed and diastolic flow, we need to do cesarean section at 32 weeks. So this is important. Now coming to Robson classification, which is given by WHO. According to WHO, this is also called as 10-point classification, and it is used by various institutes to compare the rates of cesarean section and indications of cesarean section. There are 5 parameters which are used. The first one is parity. So parity, we should see if the female is primigravida or multigravida without previous history of cesarean section, or multigravida with previous history of cesarean section. So in parity, first you should see primigravida and multigravida. In multigravida, again 2 types with the previous history and